our last exemplar. So go ahead and kind of prefacing with the idea that this is all kind of inflammatory GI issues. So at face value, they're going to sound very much the same. So in your studies, it's very important to distinguish the thing that makes it hallmark or precedent over something else. So for example, when you think of cholecystitis, where is the pain going to be located for that? Not cholecystitis means what? Gallbladder. So where's the pain going to be for that?
In your right lower.
Right upper quadrant is where that's going to be. All right. What about for pancreatitis? So it's actually, yep, it could start in the epigastric and radiates to the back. So Chuck's got that. Appendicitis, right lower quadrant. So if they just come in saying abdominal pain, that's not going to help me get where we need to go to figure out which one of these problems they have. So, and there's going to be many more examples. So when we get to the hepatitis, we're going to lump it together because it's all going to result in liver failure. So we're going to talk about what liver failure looks like for those patients. And then where they picked up the hepatitis is going to tell us the A, because that's kind of the distinguishers between that. Are they drug users? Is it bloodborne based? So that's going to put us to types B and C. Was it food or contaminated water sources? That's going to put us to A and E. You know, and then for them to have hepatitis D, they have to have hepatitis B first. And so try to make things different, because as far as your signs and symptoms are going to be very much the same. So focus on what makes them different from each other. So the 6 that are technically covered in this, even though we touched on celiac disease with elimination, we'll touch base with it again today, but wanted to intro it just for sake of time, because the other ones are going to eat up our time just a little bit more, but those are the ones that you'll have there. So when you see IBS for this module, it is inflammatory bowel disease, it's not irritable bowel. So that's a different process, okay? So first, let's start with what is inflammation. Obviously, it's going to be our body's response to a potential invader. It's trying to inflame by sending both fluids, phagocytes, things like that to the area to try to fight off that potential invader. And so there was a funny meme that I thought it would be distasteful to put it on here, but it says, "I'm not obese, I'm just chronically inflamed."
That's me.
That's what I'm sticking with. All right, so chronically inflamed. So why we get inflamed, protective mechanism, and that's going to initiate healing. So it is a good response. The problem is when the body does not understand that the response is no longer needed, or we've tried to make amends and the inflammation continues. That's where we start setting up infections and all of these secondary problems that we're going to look at. And then specifically, inflammation involves your immune cells. So what class of blood cells are going to respond here? Your white, so we're going to look at that on your CBC. Your blood vessels, so all of those little capillaries that go off of the vessels are what's going to be used, and they're going to kind of make these tide pools, if you want to think about it that way, to where these immune cells are going to live, and it's going to try to absorb it into that extracellular fluid rather than trying to leave the invader wherever it is. It's going to try to pull it up or suck it into this little pond, and then let these immune cells start fighting at the phagocytes. And then lastly is those chemical mediators. The most common one's going to be histamine reactions. And so we'll look not so much at the patho there, but we'll talk about some classes of medicines that work on those chemical modifier or chemical mediator class. So first thing we need to look at is your signs of inflammation. Very wordy slide, but the picture sums all of that up for you. So you can remember the acronym PRISH for those. So obviously P first is your pain. And so we expect some or slight pain there. That's just due to, think about, you have all of those new, the fluid, the immune cells, things like that pressing on those nerve receptors in those tissued areas, and so that's going to cause some discomfort. Redness or heat, and that is just the increased vascularity that is in that section of the body. So we're going to feel hot or warm. That's okay. And then The technical term for it is functionae laesa, or if in Latin, but loss of function, immobility, due to all of the pressure, especially when you get around joints like elbows and knees. It's very hard for those parts of the body to move due to the tissue and extra pressure. And then we're gonna have swelling, so the edema, and then lastly is heat. And so that's a part of that increased blood flow as well. You can also create localized fever if you wanna think about it that way. Also trying to burn off if it thinks it's a bacteria. But if you'll know your signs of inflammation, that tells us it's an inflammatory disorder. And so we're gonna take a look at what happens here in your picture. We're gonna say that you got pierced with either a nail, a pin, sharp object, what have you. And so that's going to initiate our response from those chemical mediators. And histamine is your most common. So it's gonna send the histamines there to send the signal to say, send help here. And then in your second picture, that's where our immune cells will actually respond and to try to engulf the invader, and also to put some, what would you say, good guys, platelets, other things like that to help clot off if there's any bleeding. And then finally, the phagocytes will remove it, break them down, and they'll be metabolized out of the body. Basic understanding, you do not have to spend a lot of time there. But when you have purulent drainage from a wound or whatnot, most of the time that is just your leukocytes, your excessive white blood cells that is removing there. When it has the odor in it, we know that it is infected with some type of microbe, and so when we perform our wound cultures on that drainage, we're able to determine specifically the antibiotics or the antimicrobial that they need. Moving on. So I just pulled the pictures off in a separate slide, so they're a little larger, easier to see without all of the font. Next up is looking at acute versus chronic. Obviously, acute means short period of time. It usually is self-limiting, and then it is going to be those processes that come on quickly, like appendicitis and pancreatitis, cholecystitis, those things that just kind of hit quick, they're gone quick once we intervene, things like that. Our chronic inflammatory diseases is going to be like our bowel disease or celiac disease. Those are irreversible, and they will have periods of exacerbation, or we can call those acute exacerbations of a chronic condition. But that is where they chronically have it. There's nothing we can do to fix it. We'll just focus more on symptom management and trying to keep them into remission. All right, local versus systemic. Local reactions are going to have your 5 signs as we know it in the exudate. It is specifically right in the region of where the issue is. To turn into a systemic response, we then start spiking a fever, our white count begins to elevate, and then that's where you start getting those, like what we call the flu symptoms. So just kind of that achy, malaise, fatigue, just that general feeling of unwell. So some tests that will specifically mark you for inflammation. Our white blood cell count, that would tell us if we had an invading microbe on board. C-reactive protein, one of our inflammation markers. Erythrocyte sedimentation rate, that is looked at most of the time in patients like sickle cell anemias, where we'll see that run a lot, or in rheumatoid arthritis, but it is another inflammatory marker. And just what that type test is looking at is it looks at how long does it take your red blood cells to fall through the plasma down to the base of the tube. It's how long does it take them to settle or clump. Then we have some other tests where we can test specifically for viruses, hepatitis being one. HIV and Epstein-Barr run the great likelihood of also giving us hepatitis, SARS, herpes, anything else that could, just testing for germs that would most likely, very easy to get hepatitis, we'll see that soon. but we'll look at specific viruses. They call them a torch. There's another panel. What do they call that big panel now? Those who work at East Alabama, they all want to pick on you, maybe in the ER. It's just that gamut where they test literally for every little, so they'll do a respiratory panel and they test for all the common respiratory bugs. Or the BioFire, there's another one called a torch, but anyway, it checks for the like common bacteria, and then helps pinpoint. Imaging, we always use our friend the CT, or we can get very pinpoint and use just a ultrasound, MRI being your hardest image, PET scan. Do y'all remember ERCP? It is not listed there, but the endo, coleo, retro, pancreato, ultrasound, but that's looking at all that little metabolism triangle, liver, gallbladder, pancreas, ERCP, you can add to that list. And then colonoscopy, that's gonna be our plan of action for our bowel diseases. So it might be some tests you'll have ordered for your patient. We mentioned some treatment options here. This is specifically for, when you look at mobility next week, some of this will overlap to mobility, but just to touch base. If it's muscle-based inflammation, like sprains, strains, marathon runners, things of that nature, then we're gonna recommend RICE, which stands for rest, ice, compression, and elevation. We would offer for them, in addition to some sort of NSAID would be also recommended. If we could, again, due to muscle ones, we will do immobilization devices to try to allow that muscle to rest, not placing any additional stress or movement on it, with all of those devices listed there. Couple of medications we can give. Steroids, those are great for anti-inflammatory. What are some, what would you say, reactions or side effects of using steroids chronically, long-term steroid use?
It actually decreases, does the opposite.
Which one?
It does the opposite, it actually decreases your immune system.
It will decrease the immune system. Osteoporosis is my other big one. So for steroids, think about for those who've had the flu before or something, where they give you a Medrol dose pack. Or for a sprain strain, Medrol dose pack. What does it do? Do you take the same amount every day or what? It's a taper, thank you, Josh. So with steroids, you're gonna have to do some teaching about tapering. So they'll start on day one with usually their recommended dose, which is just a big old hit of steroids. But so we don't cause any adrenal crises, they're going to taper that dose down over the next few days, most of the time 5 days. But know that about your steroids. NSAIDs, you can pick your favorite, ibuprofen, naproxen, things like that. Just revisiting, since we have pharm on this test, what are your NSAIDs notorious for doing? I like your kidneys and GI bleed. Those come to mind there. Love that. All right, your biologics, this is gonna be our new class. This is gonna be for our inflammatory bowel disorders. Those are gonna be all the drugs ending in MAB, DAB, Imudab. You'll see them, but those will be our biologics to help with the autoimmune response of those diseases. Antipyretics, you could argue Tylenol or aspirin, either one for there, just having an idea there. So if my patient had hepatitis, what antipyretic would I use if I had a systemic inflammatory response?
Would it be Tylenol?
No.
Because it's
So I would go with which one? Aspirin. You could use aspirin. Yeah, but ibuprofen could too, because we could argue it's an antipyretic. But it just gets you to thinking which one can you pick based on your patient's condition. Analgesics, so any of those pain ones that are not already listed under NSAIDs. But about analgesics, which class might you want to avoid if we have a bowel issue? Your opioids or your narcotics. So good. And then antimicrobials, we'll look at some of those based on, so antifungal if it's a fungus, piperacillins for like upper respiratory, things like that. Okay. Hitting them quick. So if you want to make your day in a little nutshell, because a lot of these will repeat, so your assessments will always be with your vital signs, a good pain assessment. The PQRST model is one that we often use in advanced practice, but it's a good one. But it's trying to get specifics of, like we said, we can't just go with abdominal pain. We've got to find us a pinpoint. What does it feel like? Is it gnawing, throbbing, aching? Get some quality factor, that's the Q. Does anything make it better or worse? What alleviates the pain? Is it positioning? Is it a certain time of the day? Is it all the time? Is it come and go? Redness, swelling, drainage would give us signs that we have an inflammation issue. We would have warmth and tenderness. And then lastly, the range of motion is usually going to be limited. So for example, when we talk about appendicitis, we're gonna talk about how usually their right leg, they'll want to kind of put in that fetal position or draw up because it helps to relieve the pressure in that quadrant. So making them go straight leg or jump off a table and jar will really agitate that. And so we'll see how range of motion is affected with this inflammation. So we would give any of the drugs we just talked about previously on the slide. We would apply cold or heat, and depending on the situation, we will do one or the other. For example, with appendicitis, we're gonna learn in just a second, we would not want to apply heat because it's going to cause vasodilation and will go ahead and make the appendix rupture. So for that patient, we could use a cold compress, and we'll see the opposite for some other ones. We're gonna elevate the area if possible, if it's like on an extremity. Wound care, and so go visit your wound care. Remember, best practices for sterile wound care once it's past that subdermal layer. And managing on inflammation. So for example, for celiac disease we talked about last week, what's the only way they're gonna decrease their inflammation? Avoid gluten, gluten-free. And so we're gonna show you some weird places gluten hides today. And then finally, make sure it's working. If it's not working, seek expert opinion. And then make sure that our symptoms are on the up and up. So, for example, if there were, it's not going to be on my personal exam, but just getting you thinking about how HESI loves NGN. So we're gonna say, here's my patient's lovely clubfoot, and we're gonna say that at the beginning of our shift, they had some inflammation right here, looks like cellulitis. I know we talked about that with infection, but just getting you an idea. And so 12 hours, all right, and we marked it because we're good nurses, we marked it, and we put that at 0700. That's what it looked like. And then we come back at 1900, and now looks like this. We getting better, we getting worse? Worse. Right, easy enough so it's outside of the border. And then like white count would go up, and so it might have some different things for you to mark up and down on HESI about the condition. So if the wound or area of redness goes outside the initial margin or outside the original border, it's a sign it's worse. Or the area of redness is going distal or to the border, or narrowing from the border, something like that. That would tell you that the redness is improving, that we're starting to clean things up, stuff like that. Or if your white count was going down, that means antibiotic therapy's working. So have some indicators lab-wise. If the ESR was going down, CRP's going down, they're getting better. What things would you watch to know it's getting better? All right. So that's kind of your intro stuff just to get you in the wheelhouse. So now we can actually talk about specifics. So appendicitis is going to be most oftenly caused by a fecalith, fancy word for a poop stone. So just poop and mucus from, or dried mucus from the colon falls down into that little bitty appendix and starts to necrotize there, and it results in appendicitis. This is most common in your adolescents and your young adults. specifically males. Usually you'll see your young guys winding up with this, but, your book does not say one gender over the other, so we're gonna leave it with just adolescent and young adult. And then what happens is, like we said, that stone gets down in there, causes bacterial overgrowth, and our biggest concern is that we rupture, because then all of your bowel contents can go out into the peritoneum. So most of the time, your patient's gonna complain that they have periumbilical, so around the belly button, they're gonna have this little diffuse pain, and at some point, it's gonna shift down to that right lower quadrant, and we are going to have, our onset of appendicitis. We hope to catch it early when it's just periumbilical pain, but unfortunately, sometimes we wait till it's full on. Your patients will also have what they call rebound tenderness, and that's at McBurney's point. So if you want to draw you, and did our eraser go flying again? Somebody keeps taking our erasers down here. So if we had our abdomen in 4 quadrants, obviously our right lower quadrant, and it's gonna be dead center of that right lower quadrant, you would press in to your patient's abdomen. That should actually, believe it or not, relieve the pain, because it's not pushing against that peritoneal lining, it's kind of relieves it. And then when you let go, you have that surge of pain it's 10 times worse when you let go than when you were pressing on that area. So McBurney's point, right lower quadrant, dead middle of that, you can gently palpate your patient, and when you let go, rebound tenderness. They're immediately NPO, and the reason for that is 2 reasons. If you eat anything else, what are you doing from up top in the GI tract?
Just pushing it out.
You're pushing more pressure down on it, could worsen or make it perforate. The other reason is, what's probably the best course of action for this patient? Get it out, and you can try conservative, not gonna fix it usually. We're gonna go ahead and head to the OR and have, our laparotomy or laparoscopic, appendectomy. IV fluids for hydrational purposes, since we're gonna be NPO. Pain management within reason. Remember, which class would we avoid for this group, because we don't want to.
Narcotic.
It's actually gonna be the opposite, believe it or not. So we're going to give them the opiates here. We can slow them down, because GI motility might help it rupture more. So narcotics are okay. We're going to avoid laxatives or enemas, things that would promote motility, because it could cause it to rupture. We talked about, we're also going to avoid heat. So no laxatives, no enemas, no heat. We're gonna prepare them for surgery, so all of the things that you talked about perioperative, again, informed consent. If their H&H is low, just in standard testing, anything that you would do perioperatively to take care of the patient. And then post-operative, we would take care of those 4 to 5 lap incisions, usually covered with that purpley glue, Dermabond. Want to restore return of bowel function, make sure they're able to tolerate a diet. And then what class of antibiotics do y'all usually like for perioperative? What class of them? Thank you, Haley. But you got there, yep, cephalosporins. So we like cephalosporins, probably gonna get it at a dose before, during, and after when we're treating them here. Okay. I promise I'm clicking. All right, then I have done all of your homework for you, putting your HESI hints right here on the slide. So if you just kind of want to think of these as your flashcards, you want to print off those slides and make them your flashcards to study by, and maybe quiz each other on, this is the problem your patient's having, what do you think's going on? So that right lower quadrant pain is your hallmark here of all these bowel inflammatory problems. Rebound tenderness, so the pain is worse when we let go of that spot. They're NPO, not only because it worsens, but also in preparation of surgery. Our biggest issue that we're gonna have big problems is if the pain suddenly goes away. So we have perforated, because all of that pressure that was building up in that little sac has gone. That's our greatest issue, so we're gonna phone the doc ASAP. Hey, think we just perfed, can we go on to surgery, because they're gonna need a washout. And even in cases of intact appendixes being removed, please still monitor them for peritonitis, very common secondary problem. And then I put your hallmark words down there again. Rigid, board-like abdomen, so their abdomens will be hot. You could use them as your Blackstone, your little flat top grill outside, because that's what they're gonna be. And just very firm and distended. It's not gonna appear distended, but just tight would be a better word. And then positioning, we talked about how they like that right extremity, they'll draw that right extremity up. And then so you can have them do an external rotation of that foot, and that'll agitate that appendicitis, because it's pulling on that muscle that runs through there. And that can help you pinpoint that it's appendicitis if you need to. Okay? This thing's gonna fight me all in. So this is what your patient would complain of, or a classic patient, textbook patient, might look like if you were getting a question on them. So they're gonna complain they've had a really bad stomach ache, started near my belly button, or they may say it's on my right side, whatever. Right lower quadrant pain, rebound tenderness and McBurney's. They have nausea, vomiting, maybe a low-grade fever, and then they do not have an appetite. We would have an elevated white count, because it will elicit a systemic response, especially if it perforates. Your CT of the abdomen would show appendicitis, and we would place them in PO. So think about how many questions we could ask, or give you a patient chart that looked like that. And you remember the bow ties, bow tie questions, so you put your diagnosis in the middle. So what are two things that would be nursing interventions or things for you to do assessment-wise? Give me some assessment stuff for if we were doing a bow tie question. So I'm gonna draw one. I'm gonna put appendicitis right there. I'm just gonna put appendix. And then we're gonna have nursing, and we're gonna play this with all of our cases. Assessment. And then parameters. To monitor. We're gonna need two. So what are some things that would be important to assess related to?
Rebound tenderness.
Alright, that could be one, but give me that landmark. So you can do McBurney's.
Yeah.
I like that, that'd be good, we can do that. Or what else? We assess.
Pain.
Good, pain. There's two, we're just gonna keep writing down here just because.
The positioning of the
Wouldn't necessarily be an assessment. What are you gonna stick in your ears? A very easy one to do for a bowel assessment.
Listen to them.
How about auscultate? Bowel sounds. What would you anticipate if they're anorexic, inflamed, hadn't eaten anything?
Decrease.
diminish.
That would be hypoactive. Could be, so they would auscultate hypoactive. What else could you assess?
Fever.
I like it, so any of those vital signs that were marked, that would be appropriate for that. Alright, so parameters to monitor, what kind of labs would you look at?
CBC.
You could do a CBC, specifically a WBC. What else could you look at? CT of abdomen, pelvis. Okay, what else?
Pain score.
Pain again. Got eyes, nose. Is there restoration of bowel function? That'd be after.
If the pain goes.
Incision healing, you've already got your pain score. So, just think about how we could play these as a bow tie. Cause we have some practice stuff coming up in just a bit. I'm gonna try to hit you with the quick, fast, and in a hurry while you're fresh. So, that's your classics. That's how it's gonna appear. Now granted, everybody is an exception to the rule, but if they're a perfect little patient, they're gonna fit inside of that little bubble. So, what's your most common cause of appendicitis? Fecal F, what age group is most affected?
Teens, boys.
I like that. What is rebound tenderness and why is it significant finding in appendicitis?
You push on it and then it's excruciating 10 times pain when it comes back.
Yup. What else?
The reason why it's significant.
Is anything else you're gonna learn about gonna have a McBurney's point?
No.
That is one specific thing to appendicitis, like there is no other indicator for McBurney's than appendicitis. So that's what we like, that's why it's significant, cause that's the only thing it could be, if we elicit that response. Let's see if there's any more of those from your prep on appendicitis. Postoperative teaching should be provided for a patient after an appendectomy. What would you teach your patient after an appendectomy? Because what we say are incisional healing, so what are they not gonna do for those dermabonds for the next couple of days?
Pick at them.
They're not gonna pick at them, they're not gonna.
Can we shower?
There you go.
Can we shower?
We can shower, but we're not going to submerge body water, so pools, baths, jacuzzis, all that stuff. I like your strain deal, that should be, we should restore bowel function, so if you have issues with constipation, give us a call. Okay, what else?
Soft ice.
Like that. Who? Soft diet, oh, just bless you for soft, okay. What did we say our greatest secondary problem was? Monitor for signs, so you're gonna teach them the signs to report for peritonitis. So if your belly gets hot, if your belly gets tight, and all of those things. If you start spiking a fever, general malaise, all that systemic infection stuff is what you would have them to educate them on to call you if they have those issues. And I like your GI diet. Start soft and we'll slowly advance them back up to something more tolerable. Incentive spirometer, because they probably had to have general anesthesia to have that surgery. So signs and symptoms of pneumonia, report that. Taking your pain medicine, whether you have pain or not, routinely to keep your pain down low rather than waiting for it to become an 8 or 9 before you do something. All of those good things. If they get antibiotics, you're all in your antibiotic education. So you see how we can just rinse and recycle everything we've done at this point. So just really focusing on the disease part, because most of the other things for this semester are gonna be repeat or crossover information. So inflammatory bowel disease. This is going to be an umbrella term, very much like COPD was for chronic bronchitis or emphysema. You're gonna have the umbrella term here for ulcerative colitis and Crohn's disease. Both of these are autoimmune in nature. And the only difference is going to be the portion of the GI tract that's affected. So ulcerative colitis is typically going to just be the large colon, but can affect portions of the small intestine, but it's usually just the large colon. And then Crohn's disease, we call it mouth to anus, is gonna be the whole entire roadway, because we're gonna talk about some cobblestoning. Like we said, it's already an autoimmune response. There is a genetic predisposition, strong tie to genetic linking, so if parents have it or a parent has it, very likely that the child or offspring could have it. Environmental factors play into this, usually the types of foods that you eat more on the acidic side, especially when looking at ulcerative colitis because of the erosion that can happen, so it's easy to upset it. And then this chronic inflammation due to environmental, so say if they're allergic to a certain type of food, it's not a bad enough allergy to create a systemic response, but you have a chronic localized response, and so your colon is chronically inflamed, it will eventually just erode and turn into ulcerative colitis. But after the damage is done or your body's used to that response, We hope to put it to periods of remission, but just knowing that stress can re-agitate an ulcer, or certain foods can re-agitate the underlying ulcers and open them back up. So, again, they're gonna have this abdominal pain, but their hallmark's gonna be that it's a more crampy style, especially following meal times, will be their biggest complaint. And then weight loss due to, thinking about especially Crohn's, where it's the entire GI tract. Thinking about food is not able to cross over or absorb, so they're not as likely to get the nutrients that they need, so which will result in weight loss and malnutrition issues. But the hallmark here for this one again is gonna be that crampy abdominal pain, and then really agitated after meal times. Things we're gonna do for them is fluid and electrolyte balance. We can revisit that, so hydration, and one electrolyte specifically that we love for GI issues.
Potassium,
Love some potassium for GI issues.
and followed by.
So this group of patients is gonna get those anti-inflammatories, immunosuppressants, and those biologics. So they'll get all of your, SONs, like for your steroids, get those, immunosuppressants and biologics. Steroids is great, great class for this one. We're gonna give out a bunch of steroids. But you're also gonna see those biologics ending in MAB and DAB. Nutritional support, so based on weight loss and all, what type vitamins would be affected? Would it be your fat or your waters?
Your water.
The opposite, because if we have weight loss,
Oh,
we don't have as much fat, so your fat soluble vitamins. So which ones are your fat soluble? It's been a while since you had those. ADK.
ADK.
Or ADEK, but yep, okay. And then B and C are your water soluble. So, so for your nutritional support, you can put fat soluble vitamins. And then pain management for those ulcers, so anti-ulcering agents may be indicated. Some pain, NSAIDs, or your anti-inflammatories would be great. Emotional support, so thinking about what's our likely treatment, because if we need to provide bowel rest, how are they usually gonna do that surgically? You say, you draw me the picture, ostomy, good, Drew. So these patients will most likely wind up with an ostomy to provide for bowel rest or better bowel function. And so you can imagine the body image, disturbance in body image, things that go along there. Or just the emotional thing of always needing to be near a bathroom because of the sudden urge to go, because food agitates it, and not being a regular, normal, quote unquote, normal person. And then all the teaching that we're gonna do to try to get them their specific diet. So, thinking about who winds up with this, we talked about it affects, like our first one, all genders, fair game. It's most of the time gonna be discovered by the ages of 15 to 30. So again, the adolescent to young adulthood, we're gonna have an idea that they have this problem. We talked about there's a strong genetic link. It is a chronic condition that can have periods of remissions. It is not curable as far as it will not ever not be there, so it won't go away. Autoimmune in nature, so that's why those biologics and immunosuppressants are great medications for this group of patients. Your differentiator between the two under the umbrella, remember that you have your ulcers, typically in the large colon, large intestine, can affect the small but not as often, and that your Crohn's is gonna be your cobblestone, the entire roadway, mouth to anus. So their mouth will have this cobblestone appearance, and so what it is like a little plaquing, or a little overgrowth, if you wanted to look at it that way, that's going to block nutrients from absorbing. So the first indicator is to mark the difference between Crohn's and UC, so that's your big one. One's gonna look ulcerated and irritated, so if you had a picture, I mean, it's gonna have that cobblestone, and we'll show you some actual, let me pull those up. Some colonoscopy pictures. So, your ulcerative, if I can get that bigger, no, this one be big.
My own?
I just get the picture. There you go. All right, so based on those, see how it's colitis technically, but anything that's ulcery looking, would be there. Where Crohn's is gonna have these white plaquey looking areas, but it's usually more severe. This is not at all severe Crohn's, cause that's just one place, and we'll try to find you some more severe Crohn's in the hospital. There we go. That's a better one, it's got those white plaques all throughout there. Hmm? Shoot. Let's see. There's a good one up there. See how it's got that stony, like your old roads in Italy or whatever, like the brick cobblestone walks? That's a really good one. And then it's got those little white plaquings through there, and those are just the Crohn's type ulcers. But, that is your classic textbooks up here in that top right. It just looks like that downtown Opelika brick that you're driving over.
So you'll see that in their mouth area, like if you look.
Yeah, it could be in their, esophagus and on down, and sometimes in the mouth in severe cases, so. Alright. Moving on. So distinguishing between the two, you have a picture, you can tell based on the ulcers. The most common, complications is gonna be toxic megacolon. And that's just where it is so inflamed that it is just literally, the whole colon's gonna burst, for a lack of a better picture. So very likely for complications there, with peritonitis, sepsis, death, things like that. So you really wanna get a handle on the ulcerative, disease when we first know about it and do some major lifestyle changes. And then fistulas. So what are your fistulas? Y'all seen some of those colovesical fistulas in clinical already? Hmm? Tunnel from one to the other, because think about the chronic inflammation, so you have that chronic friction and rubbing, especially if you have a full bladder or full vault, as they call it all of the time, it can create those fistulas, where stool and urine can interchange. That's your most common, but you can certainly have them anywhere else, but usually the bowel bladder fistulas are pretty common. Nutritional needs, we talked about, they're gonna have malabsorption due to either the ulcerations and the anorexia that goes with that, or from the cobblestoning to where the nutrients cannot cross over the small intestine tissue. So we're gonna worry most specifically about their fat-soluble vitamins, so again, A, D, E, K. And then they may require TPN or enteral feedings, either through a PEG tube, NG tube, something like that, to try to help supplement, because rather than bombard the system with 3 heavy meals, we'll try to just give them something chronically overnight. So if they're for home use, most of the time they'll just tap in either through a PICC line or a PEG tube in the evening time, just get it while they're in bed at night, and then wake up, they have their hopeful nutrients for the day. And then we talk about the psychosocial support that they may need because of the initiation of an ostomy, and then also the being near a bathroom lifestyle, because they have no control over when those ulcers would get inflamed or loose. So if you had to pick between the two, which one would be most common to have a GI bleed? I like the ulcerative. UC would likely have the GI bleed. And then if we have have a gross amount, or they tell you that they're just pooping frank blood, it may indicate that they have a hemorrhage, and so we would need to hospitalize them for treatment and blood transfusion. So, now that we have our little hints to help us diagnose these folks, I did miss one drug class, let me go back. So right here in the middle under medication management, you may see sulfasalazine, which is a relative of aspirin, if you wanna look at it that way. But it's gonna kinda help dry things up a little bit so that it does not cause UGI bleeds or bleeding. Kinda help dry them up. Okay, I think that's it there. So let's look at your classic, or what your patient would be if you had a little chart on them. So they're gonna complain about having diarrhea and abdominal cramps several months. We could even go on to say that the abdominal cramps occur most often after I eat something. So persistent diarrhea, loose running stool, crampy quality pain, rectal bleeding, most often with UC, but you can see it with Crohn's. And then more for this last, the weight loss, more associated with Crohn's, because that's one where they really cannot get the nutrients across. And then Crohn's is most common with females, even though we said inflammatory bowel disorders are not gender specific. Crohn's does happen more often in your females. Teeny tiny frail people, and so they're fatigued both from the malnutrients and but usually the low H&H. And so if we look at their labs, they're gonna have an elevated ESR or CRP. Most facilities run the CRP, that's the one we go with, but we do show you ESR in case that's the one your hospital prefers. Colonoscopy is gonna show the inflammation or the ulcers or the cobblestoning. And most often to diagnose it, we're gonna do that a colonoscopy. We can do a tissue biopsy or a tissue sample to confirm if needed, if the pictures alone aren't significant enough. And then your stool studies would be negative for an infection. So if it's not caused by an infection, then we would assume it's an autoimmune disorder, and it places it in this umbrella. We talked about your usual treatment is gonna be either the colectomy and just a small section, again, mostly for ulcerative colitis here, but if there's a small section of the bowel that's affected, we could do a colectomy and hopefully that fixes the issue. And then we could just treat, and knowing that the rest of the colon could wind up with UC because it is a chronic condition. But in severe cases, like for Crohn's, we would do an ostomy to try to bypass the large sections of the bowel, try to give it some rest so that we can heal those plaques or ulcers. We would want to decrease or totally eliminate dairy from their diet because surprisingly, animal's milk we know is inflammatory to the body. So didn't know if you knew that, all you milk drinkers out there. And then us 90s kids got screwed with it. So that's why I'm chronically inflamed. I blame dairy. No, I'm just kidding. I was a soy baby. But animal milk is inflammatory to the human body. So we would eliminate that. Increase your fiber, but here's the trick for them. Huh?
You can't do it too much.
Not too much. You actually can increase their fiber. They can have a whole lot. You want it cooked. So case in story, have you guys ever eaten, for example, a salad versus eating like, I don't know, boiled carrots, mashed potatoes, blah, 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 whatever. So something about when you eat it raw, that does agitate your stomach more, and y'all might have had that before. So if they do have it from vegetable-based sources, then they need to have cooked fiber, so that they still get the content, but it's not as aggressive as raw fiber. They may require supplemented nutrition, so we talked about they may get a PICC line for TPN, or they may get a tube for enteral feedings. So all of the education that goes with that. So if we got the enteral feeding, either an NG tube or a PEC tube, remember they're gonna sit at the head of the bed up at 30 degrees, watch for pneumonia and aspiration, all the things start overlapping. We could be here all day. And then reduce stress and rest. So if you were diagnosed with ulcerative colitis while you were in nursing school, good luck everybody, because we know your stress isn't going anywhere. But we do want to try to get them some rest, in frequent periods. So like ADLs, rather than wearing them out and exasperating them, spread out those activities throughout the day. Things of that nature. So let's make sure you've got your questions. So give me a differential between Crohn's and UC. Weight loss with which one?
Crohn's.
Could be both, but which one's weight loss worse? Crohn's is worse, weight loss, okay?
Crohn's is tip to tail.
Yep, yep. Mouth to anus, yep, what's it look like? Cobblestone, and then what do Crohn's ulcers look like compared to UC ulcers?
Usually ulcers are red and inflamed and.
Red and irritated,
Yellow or white.
Crohn's are gonna be white, yellow, plaquey
Look like
looking.
the Opelika Road.
Mm-hmm, gonna be that cobblestone downtown, alright.
Rectal bleeding.
Let's see, what's your location for UC? Most often.
Large
Large colon, large
Sometimes
intestine,
small.
however you word that. What are two nursing interventions we could do for a patient having an acute episode of ulcerative colitis?
NPO or.
Could, you could make an NPO, I like that.
TPN.
Could do TPN, supplemental nutrition,
Steroids.
anti-inflammatory, steroids, love that.
I like sucralfate, stuff like that.
PPIs, what else? What was yours, Anna?
Oh, like GI protectants, like Carafate.
Yeah, love me some Carafate, anti-ulcering agents, okay. What can you do for UC? Sulfasalazine,
Diet changes.
you could do some diet changing, what did we say we're gonna eliminate or limit greatly?
Dairy.
Dairy, yeah, any animal milk. Love that, let's see. That's it for that one. How we doing time-wise? 4:55, so let's do a 5-minute break. See you back in 5 minutes for gallbladder.